Alright, and welcome back to our exploration of the ASAM. I hope the music's not too high. I've got sort of this going, and hopefully that's right. So, Dimension 2 is the next one. In the first video, we talked about Dimension 2 or Dimension 1, and about how to sort of document and cope with whether or not we thought someone was in withdrawal or whether they were intoxicated, and how to kind of run through that. And we suggested what to do with them, whether level 4, send them to the hospital, or 3, like rehab, and then 2, intensive outpatient versus level 1 type of stuff, where we thought they would do okay with, or no, any level of care would be fine. So now we're going to continue that discussion with Dimension 2 of the ASAM. Just a word or two on Dimension 2. This is the biomedical conditions for the ASAM criteria for 4th edition, and we're using the same fillable PDF, and we're going to kind of walk through that today. Dimension 2 in the ASAM 4th edition is to evaluate whether or not a person's physical health is going to interact with their ability to participate in treatment, and whether or not their medical needs would have an impact on that treatment. So what we're looking for is any kind of biomedical conditions, physical illnesses, injuries, chronic diseases, or even a sleep-related issue that would complicate withdrawal, treatment, participation, or safety. So we're basically going to be asking and trying to answer with this form, does this person have any medical or physical health problems that would affect how we handle and treat their addiction when they come in? So the first thing we're going to ask is, do you have any health issues that are concerning you right now? And we're going to check yes or no. I think I forgot what I named my guy. Was it Coca-Cola? No, it was Coke. Coke Spearmint, Peppermint, wasn't it? Peppermint Coke or something like that. Mr. Peppermint will say. We're going to say he does have some. We'll check the yes box right there. And so if they are, then we're going to know what it is. So what do you think is really common health? Pause and ask yourself that. What do you think are complicated things that might interact with addiction treatment? And the really common thing that I see is high blood pressure. You can type that in here, or if you want to, you can type hypertension. Hyper meaning fast, and tension meaning referring to the cardiovascular system, or high blood pressure. So it's tense in the arteries and veins, and it's hyper, so it's pumping really fast and really hard. Opioid addiction, often you see a rise in high blood pressure when they're in the early stages of withdrawal and detox. So we can kind of think, there's several different complications that would be increased risk. If they tell you they got high blood pressure, you're still going to go back up there to this on the first one, which I've got a blank form here. I didn't save the one from last time. But you would want to try to measure that here and comment on it here. Now, if they set it up there, when you get down here to Dimension 2, this should match. Because that earlier screening is sort of what was in the here and now. Right here is where we're wanting to know if this is concerning them right now. So if you've got somebody that had a high blood pressure up there, and I don't remember, let's say they had 100 and 200 over 110. That right there, you need to kind of stop what you're doing and say, hey, go to the hospital. But if it's, because that's life-threatening, but if they're at like 180 over 90 or 95, that's pretty elevated. So that's really high blood pressure. It's not, I don't know, stop what you're doing and rush to the ER high, but that's pretty freaking high. They're probably going to feel bad. And with opioid withdrawal, that's what they're going to feel. Now, there could be other stuff going on with chronic opioid use. You might have some respiratory depression that you noticed. They may have asthma. How do you spell that? Not the best speller in the world. May have asthma. May have COPD. They may have diabetes. If they were using methamphetamine and stimulants, diabetes seems to be really common with that. I think something about that makes them crave sugar or something. I'm not quite sure. But also, we're going to list these out and think about these and talk about these as we kind of go. Now, the ASAM-4 puts a big emphasis on whether or not you're pregnant and how that interacts with your play. I'm trying to figure out how to adjust my screen over a little bit. Let's see, make that a little, that's zooming in. We want to zoom out a little bit. Because, why is it zooming out? Okay, let's see. Just a second here. Oh, I see, it's down here at the bottom. Okay, give me just a second here, guys. I've got a weird summary thing that keeps popping up down there. I'm gonna make this bigger for just a second. Bear with me. How did I get out of that? There we go, hide the bar. Alright. I had a little like weird AI thing that kept popping up down there. Let's see. Why can't we make that? Well, let me adjust. There we go. There's what I needed. There we go. Thank you for bearing with me while I make that a little better for everybody. Okay, so, oh my goodness, it's wanting me to put it over in the corner for you, because I don't know what it's going to do. All right, there we go. That looks better. So, thank you for bearing with me for a minute. So it puts a big emphasis on that, and if they're female and they've not been tested, they may not be sure. Personally, I've not had that come in. We're dealing with a male client, so we're just going to click no. And if it's a male client, in case anybody's reading this and they want to see if I've done my due diligence, I'll type NA for not applicable. If they are pregnant, there's special considerations you're going to want to keep in mind. So if they're pregnant and they're on opioids, for example, there's some options for opioid treatment and management that's safer than others. The Suboxone may not be the most ideal thing. They may need to go to Subutex. Subutex is the injection that is a little safer for pregnancy, and I think the difference, let's see, Subutex versus Sublocade. Sublocade is the shot for Suboxone. That's just the normal one. And let's see. So Subutex, Subutex. That's the buprenorphine mono product. It doesn't have the naltrexone in it, which makes it a little safer for pregnancy. Also, methadone is safe for pregnancy. I always feel some kind of way thinking about someone who's pregnant taking either, I'll top that out here. Subutex. We'll deviate for just a minute. Subutex. That's how that is, and that's Suboxone without the naltrexone in it. Vivitrol and naltrexone would be a no-no. And methadone is safe for pregnancy, and so is Subutex. I always cringe a little bit to think about those things, and I know a lot of people do as well. But I just want to remind everybody here, Subutex and methadone would be a whole heck of a lot safer than fentanyl. So when you're treating patients who might be pregnant that come in for opioids and they're on board for an MOUD treatment, keep that in mind. They are making a better choice. It may not be the ideal picturesque thing that you have in mind, but it's still safer. So we're going to skip these questions because we're going to imagine a male patient, right? But I'll deviate here just a little bit to talk about this some as we go down through here. So if they are female and they are pregnant, we want to urge them to get prenatal care from a doctor. They're our patient if they come in to see us, but we want them to get the best care possible, because self-care is honestly going to help them, sort of take care of their self better too. If they've got something to live for and something to work towards that's positive, and a child would definitely be positive, then getting the correct care for that would be where we want to kind of urge them. Have you ever had any pregnancy conditions like high blood pressure, gestational diabetes, preeclampsia, placental problems, premature labor, or others? We want to notice those too, and we're going to defer to a doctor medical as much as possible here. We're just going to be the sort of spokesperson to urge them to get that treatment that we know they need. Gotta have some Coke here, guys. My mouth gets dried up. So the ideal here is, if it is a female, we're going to put referred to a medical doctor for a consultation. So what we want to know, we want to document that, but what we're looking for and what we're looking to clear for any client is no known pregnancy related issues that would prevent participation in SUD treatment. So that's what we're looking for, though. So we're wanting to make that proper referral. We're wanting to think about how we should already be sort of in the mindset to be thinking about how their pregnancy might interact with treatment. So if we're just looking at outpatient treatment, then maybe we can schedule around that. Now, if we're looking at residential or IOP treatment, this is something we'll want to revisit. IOP is going to be 9 hours or more of therapy per week, and typically that's done. Typically IOP is 3-hour group sessions. Something like Monday, Wednesday, Friday, 3 hours from 1 to 4, something like that. If it's centered for working people, it might be from 6 to 9, 3 times per week. But the point of that is can they do that if they're pregnant? If they're in the early stages of pregnancy and they're looking at 6 months of therapy, they're going to be 6 months pregnant when they get to the end of that treatment. Is that something they can still do? So kind of keep that in mind and kind of think about it. And also remember that you can reassess as you go along. So let's keep that in mind. All right. So we want to gauge how the client feels. So let's go back to our Mr. Peppermint, Coke Peppermint here. We're going to ask him, how concerned are you about your current health issues? And if he's got that high blood pressure, he might have heard some stuff about some people, and he might be a little concerned about it. So you would check somewhat. If he just brushes it off and says, I ain't worried about it all, my dad had high blood pressure and he didn't do nothing for it, and he lived to be a ripe old age of 73, well, that might be okay for him. If he's not concerned, he's not concerned. Might be very worried about it and very stressed out about it. But we're going to imagine that Mr. Peppermint tells us, well, I'm a little worried about it because I'm starting to have a little bit of chest pains, and I've heard people coming off of opioids or whatever have some cardiovascular issues. So we're going to say, well, when you're thinking about these health issues, you've got high blood pressure, you've got diabetes, you've got hip problems, you've got back problems. That's what got you on these opioids, blah, 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 blah. How does your current health issues impact your ability to take care of yourself? Can you bathe yourself? Can you get yourself up and groom yourself? Do you dress yourself just fine? Do you eat just fine? Can you keep your house clean? Can you do all that stuff? And if it's really high functional person that you have, you might just think, okay, well, no, not really at all. But kind of gauge that person. If they're coming into your office filthy and they smell like dirt and they smell like butt, they can't groom themselves, their hair's all over the place, then it might be, just somewhat. We're going to imagine Mr. Peppermint don't smell like peppermint and he don't bathe correctly, so we're going to put that there. It could be a lot more severe. They could be completely undressed. They could not have clothes. Once when I worked at rehab, we had a guy show up just in a set of scrubs the hospital gave him. That's all the clothes he owned. And his physical health and his addiction is what got him there. We have to kind of think about those things. Just how does that affect him? And the reason we're asking ourselves this question here like this isn't just because we're wanting to gauge and point a finger. We're wanting to know, in our mind, we're wanting to think about this in such a manner to where we can say, well, he does have some problems. Mr. Peppermint's not bathed. He's not brushed his hair. Is that affecting his treatment, though? Can he come in with his hair looking like Harry Potter's and smelling like he slept in a tent for the past week? Is he still coming to treatment? Does it bother other clients he might be in group with? Is it an issue? Can he make it to treatment? Is that something you can kind of address as you go along softly? You want to use your soft skills there. I know that's not directly approaching your substance use, but if you start talking to people about making themselves look better, they're going to start feeling better, and then that's something they'll want to keep working on. Well, yeah, that's the kind of things we want you to think about right here at this question. So we also want to ask, how much do you think your current health issues might affect your ability to participate in addiction treatment, if at all? We're going to say Mr. Peppermint's going to say not at all. But once again, the kind of things we're looking at is if he's got a bad back, if he's got a bad hip from an injury or something, that's what got him started on opioids. Or if he's used methamphetamine so much that he's just restless legs all the time and he just can't stay sit still. Or his diabetes is out of whack. He needs to get up and move around quite a bit. It's hard to sit in a 3-hour group if you need to kind of walk your sugar down, if you're a diabetic, So that's the kind of things we want to think about. So we're going to imagine Mr. Peppermint here is a guy that has high blood pressure, back pain, and some diabetes. So we're going to put the client was referred, I think how you spell referred to his primary care physician for his blood pressure, diabetes, and pain management. The client has some issue with his ability to maintain a healthy lifestyle. Okay. The client can attend doctor appointments. The client can attend regular therapy sessions with minor accommodations. He has chronic pain and may need to move around. If placed in a group, he may need time or breaks to stretch. So that's the kind of things we're looking at right there. That's what we're going to put in our comments there, so it just kind of makes sense to anybody else who reads our document. Now, we're going to imagine that Mr. Peppermint's not went to see anybody yet, and that's why we got such a high blood pressure. So when we get down here, are you seeing a medical professional now? We're going to click no, because we're saying he's not. Now, if there is yes, then we can confirm that by getting him to sign a release of information and requesting his medical records, which, depending on how bad they are and whether or not he wants to see a psychiatrist, we may want to do that anyway. So we're going to say he's not. So that means he's not taking any medications. However, what I recommend here is to not just take the client's word for it. That's always a bad idea. If you're doing this in the state of Kentucky like I am, you may want to run a Casper if you have someone who has access to that. If not, you may want to get a release of information for the pharmacy and request their current prescriptions, especially if you have any reason to suspect they might not be telling you the truth. Now, if I have a client that comes in, they say, I got high blood pressure, I'm a diabetic, and I've got serious pain issues. They said, well, I ain't taking nothing for my pain right now, but I do see a doctor and I'm on metformin, real common diabetic medicine, and I'm taking lisinopril. If they tell me they got blood pressure issues and diabetes issues and they're taking lisinopril for their blood pressure and metformin for their diabetes, I may follow up on my health screening and say, well, do you remember what your last A1C was? And if they tell me that's, within a sort of normal range for diabetics, once again, I'm not a medical professional, but, if they say, oh, I've got a 6.5 on my medicine, well, I can kind of Google that and see that that's a good target for a diabetic. So I might be okay with that. If they tell me they got an 11, and I Google that and I know that's really high blood sugar, I may say, hey, we desperately need to get you in to see the doctor too. Depending on psychiatrists that they see or do not see, may want to kind of collaborate with you there as well. But if you suspect they might not be honest, I would kind of lightly fill this out. If they say they're on metformin and they're taking 500 milligrams, we're going to type that in there just like that, and we're going to take that once daily. Okay. And do you take that as directed? Yep, they sure do. And because who's going to abuse metformin? And then lisinopril, they're going to take that. You're going to fill that out the same way, and then maybe they take that one correctly too. Now, if they're saying, oh yeah, I'm prescribed ibuprofen for their pain management, but they tell you a weird number, 700 milligrams. Well, they typically come in 200 milligram increments, and if it's prescribed, it's probably going to be 800 milligram. So if they tell you that, that's sort of a red flag, and you may want to follow up. But if they say 800 milligram and they're taking that once daily, then they'll maybe you kind of believe that. Maybe you do need the records, maybe you don't need the records. Maybe that's good enough, You'll get a feel for your clients the more you kind of go along. If you have any reason at all to suspect they might not be telling you the truth here, though, you definitely want to get them records. It's just good documentation and should probably be standard policy anyway. But it's not going to be a deal breaker if it's something sort of run-of-the-mill like that. Now, if they say, well, I'm taking oxycodone, and you already know that they've got a opioid addiction problem, but it was not oxycodone, it was fentanyl, this might be a problem. You might want to look into that and check and see if that's a viable pain management option that lines with your treatment or not. So that's the kind of stuff that might be a red flag for you. If they say they're taking oxycodone, and then they say, oh yeah, you know what, I've got some mental health meds there too. I also get Xanax from my prescriber. Well, that's a red flag right there. The same DEA license shouldn't be prescribing both of those. But then they say, my pain also got Neurontin on there. That's a heck of a no-no. All three of those are depressants. If they tell you they're taking those right there, that's the kind of red flag that I'm talking about. You definitely need to verify those medications if they say they're taking Neurontin, Xanax, and oxycodone. Especially if they say they're taking Xanax and oxycodone and it comes from the same prescriber. No prescriber is going to do that because their DEA license won't allow them. Typically what happens if they got that kind of stuff, they're going to more than one doctor. So we're going to imagine Mr. Peppermint here doesn't do that, and he's just said he's taken metformin, lisinopril, and ibuprofen in the past, but he's not currently seeing a doctor. So we're going to go down here to this next question. Do you feel like you need more or different care for these health issues? Now, this is worded very clinically and very kind of oof. If we say, hey man, your blood pressure was kind of high, we may need to word this in a way that's more down to earth for our client. I live in southeastern Kentucky, and if I say this in this all proper wording right here, do you feel like you need more or different care for these health issues to participate in my treatment? Well, that sounds a little pompous, and it's not that it is pompous, it's that it's worded in text and verbiage that's normalized. So we want to normalize this again ourselves to our client. So if I've got Mr. Peppermint in my office and I know his blood pressure was this high number of 180 over 95, I know he's got asthma, I know he's got diabetes, I know he's got COPD, but he's not listed any asthma or COPD meds. He may have forgot them. He may be out of that prescription. So I'm going to word that and I'm going to say, hey, Mr. Peppermint, I'm glad you come in today. I'm glad we're talking about this, but my next question is I want to know if you think you're getting adequate treatment for that. Do you feel like you're getting enough treatment? Is it adequate? If I ask you to go see your doctor, would you? And he may say no if I phrase it that way and be a little honest to me. And I'll say, well, I'm going to ask you to go see your primary care physician. Who are you seeing for that? And he might say, I'm going to Grace Health in Corbin, Kentucky. That's a really big clinic there in Corbin now. They got a nice big medical campus. Props to Grace Health. They're a good agency. So I say, hey, Mr. Peppermint, I'm gonna recommend you go see the fine folks over there at Grace Health again. Do you feel like you'll do that? And he says, oh, well, I went there in the past and that's who I saw and got the medicines I told you about. That's who prescribed those. I could schedule me another appointment there. They can get me in. So I'm going to sum that up. That's a little conversation I had with him. And I'm going to put the client agreed that he will make an appointment with Grace Health, which was his primary care. He will make an appointment to better assess and address these issues. We'll follow up with a release of information. So we don't want to contact them on, he can go to Grace Health, that's fine. We don't want to call Grace Health for him until we get that release information. We want to keep in mind ethics. This is HIPAA protected and it's protected by the other law too. I forget that one off the top of my head. There's a law similar to HIPAA that protects his drug and alcohol records too. Let's see. While that is, I'm gonna Google that real quick. HIPAA that protects. Okay, follow it similar. Let's see. Yeah, it's 42 CFR Part 2, Federal Confidentiality Rule for Substance Use Treatment Records. It's like, it don't have a cool acronym like HIPAA, so I can't remember it. So 42 CFR, if you want to go Google that one. We want to make sure we get a release of information before we follow up, because we would be sort of requesting those records and they would want to know why we're seeing him, or they would see our credential on the request fax cover or whatever, or figure out that we're giving him substance use treatment or mental health treatment. And we want to make sure that we're protecting his confidentiality and doing this. We're going to do this with his wishes too. If he tells us don't contact Grace Health and don't ask my primary care physician, then we're not going to do that. We're going to do the best we can with what information we got. But if he agrees to give us that, that's what we're going to document. That's what we're going to do. We're going to give him time to do that. So now you notice this jumps back to prenatal care, and then we're going to say, he can't do that. But it's got a little question sandwiched under that you can miss, because we got to continue treatment or prenatal care. It's kind of jumbled together. So we're going to ask if he's got problems with getting to the doctor. And Southeastern Kentucky, it might be transportation. So we might talk to him about the options that are in Southeastern Kentucky. In Knox County, we have RTEC, and we have that in Whitley County too. In Clay County, they have Daniel Boone Transit. I'm just familiar with those local areas. There could be taxi cabs that'll take them. We're going to talk to them about that if we know about those, and if we don't, then we're going to document it and kind of brainstorm it, reach out to a case manager or whatnot. Now, do you feel like you're able to attend those medical appointments in the own community? That's a yes or no question. We'll say Mr. Peppermint says he can. They can answer no, and they can give you reasons, but if you notice, there's not much of an area here to It's just yes or no. If the answer is no, we're going to keep that in mind and maybe pull that rationale down to here. So this is just a little keystone for us right here. It's green. It says interviewer assessment. Is the patient likely to need integrated medical management to participate in addiction treatment? Is it that we expect the patient is going to need medical services for co-occurring physical health or pregnancy needs or yada 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 to complete the addiction treatment, but are they also unable or unlikely to assess that concurrent care? So we're going to rationalize this out here. Are they likely to need it? Well, with Mr. Peppermint, that blood pressure is a little high. He may need some other stuff, so we don't have to do that. He's not at a risky place, and as he recovers, it might get better, but we're going to have to rationalize that. So none of the issues that the client presented would be life-threatening. So that nothing's life-threatening. We're going to type that there. Or would cause him to not be able to attend therapy sessions. So that's it right there. I mean, that's where our obligation would end. Now, I'm not the kind of clinician who likes to just end at my basic obligations. I like to think of the person as a more of a holistic approach and say, well, I don't have to follow up on any of this stuff, but if I do, is it going to make him more likely to be successful? And with this one, the answer is yes. So we're going to continue with our rationale here. The client does agree to see a primary care physician and is willing to share his medical records with the treatment team. The client, so up through there's also something else that I think the ASAM-4 kind of misses. And I always like to sum it up here and mention it here because it's like the best place to put it. Because if he was an IV user, so a lot of times with opioids, it progresses to the point where they're using a needle and intravenously shooting that stuff up. They're shooting up with a rig, yada yada yada. That happens with methamphetamine too. And the chances of them needle sharing, along the lines of this ideal of harm reduction that's new and kind of an urgent thing in our community as clinicians, we want to think about that right here because the ASAM-4 misses one big thing here that doesn't directly ask, but if we're doing harm reduction correctly, we're going to be mindful of this and start to incorporate it into our treatment when we're doing our ASAM. And it's going to be the client also agreed to get tested for HIV and Hep C. In the state of Kentucky, the reason we want to get tested for these two things is just to reduce harm. If he's got HIV, that's going to be something he wants to address immediately. If he has hepatitis C and he's on Kentucky Medicaid, he's going to want to get that treated. As we're moving people along through treatment, regardless of where we send him now, whether we're going to decide IOP, whether we're going to say outpatient, or whether we're going to say rehab, Hep C treatment, if he's got Medicaid, is paid for. And we move him along through treatment and get him to the point to where he's got a job and he starts to get benefits. Well, he may start to get just enough income that he loses Kentucky Medicaid and he's on employer insurance. I have employer insurance myself. It pays about 80% of stuff. That Hep C treatment, the lowest I've seen the copay on any prescription for any client has been like $15,000. So 80% of $15,000 still leaves, roughly $3,000 for them to come up with. And if they're barely scraping by and they find out they got Hep C when they get their new job, that $3,000 might be devastating. That $3,000 might cause them to relapse. So if we think of that now at inception of treatment and say, hey, go get tested for Hep C, it's free. They'll even give it, some places through UK will even give them a $20 gift card. We want to get that done, because if we get that done now and we address that now in our ASAM assessment, then they have a better outcome. So it's really detrimental that you think of things like this as you develop your career, and this is just a great place to throw that in the ASAM, that you put that referral in there. So that means we get to go down here to where we want to put this rating. So let's think about what I was going on with Mr. Peppermint. He's not got any life-threatening things, so hospital's right out. We're not going to do, oh man, it won't let me unclick. Well, we're not going to do level 4, ignore that. Level 4 is right out. Now, level 3 is like rehab-related stuff. I can't think of anything biomedical just by him being a diabetic, having some back pain issues, or anything like that, that would say, oh, yep, he's got to go to a biologically or non-biologically enhanced rehab. There's nothing about anything he told us through that process with his physical health that would say rehab, got to go to rehab. Now, I'm sure there's some scenarios that I've seen personally that I could think of that would indicate rehab right here, but I'm thinking more along the lines of really severe things that I really don't want to discuss in this video. Maybe in a future video we can discuss some options. But I also can't think of anything that would put him in level 2.7 where we're looking at like IOP level. No, I mean, I can't really think about that. So regular outpatient 1.7 is more of like those emergency things. We're not really seeing any emergent thing either. I think he would be good in any level of care. Now, does he have no specific needs? No, we definitely need, oh, that got rid of that check up there. When I moved it here, he doesn't have no specific needs. He's definitely got to address that pain, especially if he was an opioid addict. It could be that he's just in opioid withdrawal. It could be that he's got a physical underlying injury. If he don't address that pain, then what are we going to do? Pain is going to make him relapse if we do not address it. So it's not no specific needs. His diabetes makes it where he's got to move around some. So that's definitely an issue, but it's not something I would say he's got to go to the hospital for. It's not something he's got to be put in rehab for. Not something that's emergent. So none of the issues that he presented is stuff that we have to address right now. And that's how we have to think about this. Now, I do wish there was a little summary block here, more than just this right here, because we might need to, I don't know, document our plans a little better. And if you think about it, just what the ASAM is, it's just wanting us to do this level of clearance, to where we say, yeah, you're safe here, you know you're not safe there, blah, 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 blah. And that can be minimized to just a block here, to where we check. And if we got pregnancy-related issues, well, the same would go here. If they're really high-risk pregnancy, they may need a higher level of care here that we could kind of explore. But any level of care might be logical for a person similar to that that's female and pregnant too. But if we do have sort of things that we're going to plan out for our client that we think are detrimental to his success to treatment, we can always include that into our note for this same session. So you can write a burp note, and you can add that into your burp note about your recommendations as part of your planning section. So keep that in mind. And if you need to, you can refer back to this, and you can refer back to this transportation issue. For example, your burp note, you may want to put something like, I didn't elaborate here. You might put, will refer to case management, because adult case management can be a thing. Might be something he needs. Or if it's not to the point where he needs case management for it, because it's just that issue, you might could say peer support too. Peer support might have some good ideas for it. But whatever the case may be, you can put that in the plan section of your burp note. Now, as we're kind of going forward on this, if you want me to make another video that demonstrates how you would write a burp note or a DAP note, depending on what your agency or company wants, let me know, and we can talk about how to document this further. But for the purposes of ASAM, this is all you got to do right here. You just got to come to this conclusion here, fill in these boxes here, and sort of check this and come up with this recommendation. Now, it's very important that when you're doing this one, that you don't check the wrong box here and say no specific needs, and then 3 sessions later you're saying, oh, they got to go to the doctor because their blood pressure is still really high. Well, that's kind of silly because you said there wasn't no needs here. So take it serious and really think about what an appropriate response will be, and you'll have a better result, and it'll set you up for a better scenario with your patients. So if you like this video and it's something you find helpful and you've stuck around this long, please leave me a comment, ask some questions, generate some feedback. I had some feedback. Some people messaged me through other means and give me some feedback. Like the video, comment, subscribe, share it, whatever. All those things really do help, and it helps me pick up steam and motivation for the next one. So if you would drop me a comment, drop me a like, and share it with other people that might find it useful. And I'm going to put this one in a series on my channel, so it'll be a playlist, so that way you can play them all together or whatnot. But this one's been Dimension 2, the ASAM 4th edition. Thank you very much for watching.